Smoking is the leading cause of morbidity and mortality in virtually every country in the world and is the second only to high blood pressure as a risk factor for global disease burden. Tobacco smoking is the single most important preventable cause of ill health and death in Australia. Tobacco smoke contains over 7,000 chemicals, of which over 70 cause cancer. Smoking leads to a wide range of diseases, including many types of cancer, heart disease and stroke, chest and lung illness, and stomach ulcers. Moreover, in Australia, up to two-thirds of deaths in current smokers can be attributed to smoking. People from around 1940s was the first generation in which many smoked substantial number of cigarettes throughout adult life. Hence, only in the 21st century we can observe directly the full effects of prolonged smoking on mortality among men and women in Australia. The study I want to discuss is a prospective cohort study of 2,04,953 individuals aged more than 45 years, sampled from the general population of New South Wales, who joined the 45 and up study from 2006 to 2009 with linked questionnaire, hospitalization, and mortality data to mid-2012 and with no history of cancer other than melanoma and non-melanoma skin cancer, heart disease, stroke, or thrombosis. In this literature, for all-cause mortality among current and past smokers were compared to never smokers and estimated adjusted for age, education, income, region of residence, alcohol, and body mass index. Large-scale quantitative evidence on the relationship of tobacco smoking to mortality among countries with a mature smoking epidemic is occurring, but is not yet available for Australia. In common with many countries, Australia has relied on the findings from studies conducted in the UK and US, including the British Doctor Study and the American Cancer Society cancer prevention studies, to underpin estimation of the population impact of smoking. The risk of cancer, cardiovascular disease, respiratory disease, and a range of other health problems are increased in tobacco smokers, and as a consequence, smokers are more likely than non-smokers to die prematurely. The relative risk of adverse health effects increase with increasing intensity of smoking, measured by the amount of tobacco smoked per day. Smoking cessation imparts significant health benefits. The overall effects of smoking on mortality in population relate closely to the prevalence of current and past smoking and to the duration and intensity of smoking among smokers. These indices relate, in turn, to the factors influencing smoking behavior, including the stage of the smoking epidemic in the population under examination, to the relative success of tobacco control measures, and to cultural and socioeconomic factors. Participants in this population-based cohort study were predominantly born between 1920s and 1964 and had lived through the peak of the smoking epidemic, as well as through many changes in tobacco policy, legislation, and health information. Individuals joined the study by completing a postal questionnaire distributed from 1st January 2006 to 31st December 2008 and given informed consent for follow-up through repeated data collection and linkage of their data to population health databases. Baseline questionnaire included information on social demographic factors, health behaviors, height and body weight, medical and surgical history, functional capacity, and physical activity. A wide range of methods has been used to collect data and to interpret the results of this cohort study. Questionnaire data from study participants were linked probabilistically to data from the New South Wales Register of Births, Deaths and Marriages up to 30 June 2012 to provide data on fact and date of death. This probabilistic matching is known to be highly accurate. To minimize the potential impact of changes in smoking behavior and higher mortality in those with baseline illness, participants with self-reported history of doctor-diagnosed cancer other than melanoma or non-melanoma skin cancer, and those with a history of cardiovascular disease at baseline were excluded from this study, which makes the results very accurate. Mortality rates in baseline and 95% confidence intervals were calculated for participants who reported being current, past, and never smokers as baseline. They were indirectly standardized for age to the person-year distribution of the whole cohort population and were presented separately for men and for women. Hazard ratios, which are equivalent to and described here as relative risks for mortality in men and women, were estimated separately and according to birth cohorts with sufficient amount of data using Cox regression modeling, in which the underlying time variable was age. All statistical tests were 2000 using a significance level of 5%. At baseline, 7.7% of the study participants reported being current smokers and 34.5% were past smokers. Of the 84,312 participants with relevant data, 96 of them smoked only cigarettes, 2% smoked only pipes or cigars, and 2% reported smoking both. The prevalence of smoking was similar in men and women. Compared to never smokers, current smokers were on average younger, less likely to be urban residents, of lower income and education level, and less likely to hold private health insurance. Also, they were more likely to report consuming more than 15 alcoholic drinks per week and to have body mass index less than 20 kilograms per square meter. The rate ratio of dying during the follow-up period was 1.42 among individuals ceasing smoking at age 45 to 54, compared to never smokers. Corresponding results for 1.36 among men and 1.52 among women. Mortality diminished progressively with increasing time since cessation of smoking, and did not differ significantly from that in never smokers and individuals ceasing use prior to age 45. More detailed information you can see on the graph that is provided below. Among current smokers, the mortality rate during the follow-up period increased rapidly with the increasing number of cigarettes smoked per day, with around a double increase in mortality in the group smoking 15 or fewer cigarettes per day, 10 cigarettes per day on average, and around a 4-time increase in the groups of current smokers who smoked more than 25 cigarettes per day compared to never smokers. While there was evidence that the increase in mortality with increasing numbers of cigarettes smoked was significantly greater for women than for men, the confidence intervals were relatively wide and the absolute mortality rates were considerably higher for men than for women.
In this large-scale population-based Australian study, death rates in current smokers were around threefold of those people who had never smoked, in both men and women. On average, smokers died around 10 years earlier than non-smokers over the age examined. Mortality rates increased substantially with increasing intensity of smoking, with rates approximately doubling in those smoking around 10 cigarettes per day. Quitting smoking resulted in large mortality benefits compared with continuing to smoke.
Now I would like to share some thoughts about the weaknesses of this study. Hypertension and dyslipidemia were considered likely to be a part of causal pathway between smoking and mortality. The evidence presented here relates to deaths from any cause. Data on cause of death were not available at the time the study was conducted. International evidence shows that the vast majority of excess deaths in smokers are caused by smoking and are due to conditions such as cardiovascular disease, cancer, and chronic lung disease. However, it should be borne in mind that the minority of deaths, such as those related to suicide, may be increased in smokers but may not wholly be caused by smoking. Hence, it is hard to exclude the relatively small number of deaths that are less likely to be causally related to smoking. As we have already discussed the weaknesses, I would like to emphasize some strengths of this cohort study. Questionnaire data from study participants will link probabilistically to data from the New South Wales Register of Births, Deaths and Marriages up to 30 June 2012 to provide data on fact and date of death. This probabilistic mention is known to be highly accurate, false positive and false negative rates less than 0.4%. This study has the strength of being large and population-based, with independent and virtually complete data on the outcome of all-cause mortality. The study provides the first large-scale direct evidence on the relationship of smoking to mortality in Australia. Repeat data collection on smoking status allowed correction for regression delusion, such as the findings related to smoking intensity are likely to reflect long-term habits. To conclude my discussion, I would like to mention that the national prevalence of smoking in Australia has fallen rapidly and now is among the lowest in the world, with an estimated 13% of adults smoking daily. A number of countries are moving towards tobacco eradication. This data indicates that in low prevalence settings, the risk of continuing to smoke and the benefits of cessation still remains high.